This is Heart Rhythm TV, and I'm Daniel Alyesh, here with a global PFA update from the European Heart Rhythm Association Congress. A lot of interesting data, specifically with regards to PFA coming out here, which we'll dive into in subsequent discussions. I think the most important point about this piece and the impetus for it is kind of to bridge an understanding between the two different practice patterns in North America versus Europe. Important points and facts. In the United States and in North America, 100% of PFA cases are mapped and use ICE. Additionally, even though PFA is roughly only a year old for AFib in the United States, it is already being used in 60% of AFib ablation cases. Now let's contrast that with the European approach. 15 to 20% of those patients are mapped. 5% of patients have an ICE catheter and mapping during the AFib ablation. And despite having upwards of 3 years experience with PFA in Europe, only about 30 to 35% of AFib ablations are actually PFA. So in the subsequent episode and discussion, we'll talk about those practice differences and try to understand, are these science-based differences, practice-based differences, or cultural differences? So stay tuned for the PFA Global Update on Heart Rhythm TV. You know, the first and very important question is, now that we're in Europe, I found the guy who has better hair than me, and I need to figure out where you get your haircut.
Yeah, I will tell you in a minute. Maybe we do it afterwards.
Yeah, I guess we should focus on the PFA. A couple more important things that are coming out of EHRA. The first is the single shot champion data. And then another is your study, which I'll let you allude to after. But talk to me about lesion durability, some of the things we learned today with regards to PFA versus cryo.
With regards to PFA versus cryo, there was this beautiful presentation today from our friends from Switzerland, and Tobias Reichlin, he presented the data. And they randomized approximately 210 patients, cryoballoon versus PFA using the pentaspline catheter in 2 centers in Switzerland. And what they found was a reduction or an improved primary endpoint in favor of PFA, and primarily patients were treated using deep sedation and not GA. That's another European American difference, and also fluoroscopy guided. And what they found, as I said, is PFA was met the non-inferior endpoint and even met superiority if they were looking into the data again. So this is kind of interesting. And the key difference is those operators already had experience using the FARAP or the pentaspline device, whereas in the Advent study, it was basically novices to the technology. At least that was one of the criticisms. And therefore, from that aspect, it is interesting, I think. And another aspect was they implanted a loop recorder in all the patients, and they found that the post-ablation AF burden was very low in both groups, similar low in both groups. So there's interesting findings.
Yeah, I think it's always, and that was published in the New England Journal.
Yeah, it's published on today.
Today in the New England Journal.
Very important.
It's always very interesting to see now with experience that PFA can now be superior to thermal ablation. Everyone has their own biases in their mind, but this is really important data, especially for understanding, hey, there is a learning curve, you're getting more experience, now you can be better than traditional thermal approaches.
Another aspect was that the recurrence during the blanking period did differ with their pattern. So maybe the lesion formation or the lesion maturation also, there's a difference between the thermal versus the PFA lesions. But interesting data, a little digest, but
and fewer blanking period recurrences even in the PFA group.
Absolutely right. Yes, absolutely right.
So changing gears a bit, let's talk also about your data. Which examining the efficacy related to the olive lesion.
Okay. All right.
So for the viewers or the listeners, the olive lesion involves a smaller basket that can deliver PFA within the pulmonary vein sleeve. Now, traditionally with thermal ablation, we had a lot of reluctance ablating that deep into the vein because we were concerned about pulmonary vein stenosis. Not an issue, right, with PFA. Tell us a little bit about what you found when employing olive lesions in all 4 pulmonary veins.
Yeah, thank you. The data will be published tomorrow in JACP, and David Schack, he's the first author. He will present the data tomorrow. But I can already share that we, of course, are striving for almost 100%, or an ideal scenario, 100% of permanent, durable pulmonary vein isolation. But we realized, even with PFA and the current recipe, is not the case. And therefore, we thought how to improve the lesion quality. And here at EHRA, at the Ablation Innovation Summit, but also at the 101 Canadian European meeting, we learned a lot about lesion, but also about device sizes and also getting to different configurations. And this is the principal idea, to have a little smaller device which is slipping a little bit into the vein. And as you elucidated, there's no risk for PFA stenosis using PFA. And this allows applying 2 additional applications to improve the rate of durability also in patients who come back for a second procedure because of a recurrence. So we could significantly increase the rate of permanent PVI. So we do 10 shots per vein, including 2 olive configurations at any vein.
Oh, well, that's very, very helpful. And one important finding that is that you're delivering olive lesions in the right-sided pulmonary veins. Now, I traditionally have been delivering them in the left side to treat the Marshall tract and to make sure to have durability. I always had a subtle fear of the phrenic, but tell me about your results, if any, with regards to phrenic.
Yeah. The olive protocol, so 10 shots per vein, is the standard recipe in our center for more than 2 years. And I can at least, based on our experience, we have not seen complications due to the olive protocol.
Excellent. So I want to ask you a practice difference that we note in North America versus Europe. So you all been doing PFA for about 3 to 4 years. We are just completing roughly our first year of PFA experience in the US. The majority of AFib ablations, around 60% of AFib ablations in the United States, are now PFA. However, in Europe, you're around a third or 35%. How would you explain that difference in uptake and speed of uptake?
Yeah, of course, you guys in the United States, you are so open to embrace new technology immediately. We're a little more conservative. Multiple reasons, I believe. Multiple reasons. I think still, on the one hand, there's very solid data on, for instance, Cryoballoon, randomized trials. So we always were asking for randomized data. There's randomized data. However, of course, PFA is so promising, can be so fast, and it also has very good safety if done properly. And we here in Europe still face some challenges due to, I would call it the reimbursement topic. And in contrast to, let's say, other environments, reimbursement environments, we have a certain budget and we have to decide how we spend this budget, and this limits, of course, the rapid uptake of novel technologies. But it's, I believe, a matter of time. This picture will change in the future.
So it's interesting. So I would say there are many reasons for these differences, but one of them, a contributor, are market forces. So we can see differences in market forces in both practice environments. So final question.
Yeah.
It's gonna dovetail on my last one. If you had to get an AFib ablation, what energy source would you want?
I would go for the best operator. Probably I would consider coming to your place with low fluoroscopy exposure. If ice was needed, I'm not too sure. If you can also have a beautiful procedure with very little fluoroscopy. But honestly, I would tend towards probably going for electroporation with an established technology.
Thank you very much, Julian. Now, I understand you've done a fair amount of work in the space of left atrial appendage occlusion. In the era of PFA and post the option trial, for that matter, comment to me about how has your thinking evolved with regards to the indications for left atrial appendage occlusion, as well as concomitant procedures with PFA?
I think that's an excellent question, and obviously a development after the option trial that we seriously need to take into consideration. we started doing left atrial appendage occlusion procedures more than 15 years ago. And actually, one of our first populations was the population where we combined appendage closure with ablation, even before we had pulsed field ablation, because we thought that this would be an excellent way to not only try and treat AF and diminish AF burden and AF symptoms, but also do something about stroke prevention. Because there's certainly a group of people where continuing oral anticoagulation, as we need to do according to our guidelines, is not an option because they have a high bleeding risk or have a lot of bleeding problems. And those are actually patients, also when they're young, that could really benefit from that combined procedures. And so we always combined that, and that was in part due to a reimbursement issue. So it was cheaper for us to combine it instead of doing two separate procedures. But we've always combined them, and I think what Option is showing us now is that indeed combining appendage closure with an ablation is a good thing. It's equal with regard to stroke protection when you compare it to appendage closure and anticoagulation.
You notice in the Option trial, the event rate was actually much lower than projected, just overall in both groups. To what degree are we now needing to think about stroke risk reduction from an ablation on its own and arrhythmia burden going down? What contributor, if any, is there with that? Now, I understand that the trial was not powered to study that, but I think it's a worthwhile question given what we're seeing with modern ablation techniques.
Yeah, I think you're right. I think that the missing piece here is what happens to AF burden. The yes/no answer about AF, did anyone have another episode of AF within the year following an ablation, becomes less important. Burden may be more important. And I do agree that in the current era, it seems that maybe the CHATS VASC score is not as predictive anymore about stroke risk. And if then you lower it even with AF ablation, we will hopefully see more data on that from the Ocean trial. Because that's the trial that actually will look at stopping anticoagulation after ablation. But we need more data probably on things like atrial arrhythmia burden or the number of episodes that can tell us more about the stroke risk after ablation and whether you really need to continue all anticoagulants. Because if that's not the case, then probably the true number of patients that could benefit from a combined procedure may be more lower than we currently think.
Yeah, I think these are important questions that we need to answer with sound data. You are working in Australia on with a PFA company that gives you access to modifying the PFA parameters and understanding their biophysical and clinical impacts. Now, contrast that with our experience with commercially available proprietary products, both IDE and commercial. And I just want to learn, and I want to know, what have you learned as far as the clinical and biophysical impacts of being able to actually get your hands on those parameters?
So then I would say that most of the companies have actually gone through a lot of this process, but they've done this internally. For me, it was kind of important to try and understand that myself, which is why we worked with this company to open up their system so that we can then adjust every parameter that is available in the system. So this may be the number of pulses, this may be the pulse, the voltage of the pulse, whether it's biphasic, whether it's uniphasic. We can alter all of those things. And each of these parameters has a different effect on the lesion characteristic, right? And I'm sure we're going to find out that it has a different impact in terms of complications as well. So you think about like a pacemaker programming, you can change the voltage, you can change the tilt, you can change how much of it is in one direction versus the other direction. You can change the pulse width, okay? And so the amount of energy you get will be different. So one of the things, for example, we've been keen on working on is how do we get to that irreversible electroporation threshold? And most of the companies have gone low voltage levels, but giving more lesions in order to safely deliver this. But you could also do this, for example, by giving a higher voltage with a narrower pulse. And we seem to think that that actually makes you get to that irreversible area quicker. in this. So I think we should be
In a non-thermal way.
in a non-thermal way.
Yeah.
And because it's so short, the
Yeah.
duration. So what we need to do is actually get this in the hands of clinicians who can then have a think about what's happening in terms of what's going to occur in terms of these lesion characteristics. The proviso is that we eventually going to need to get to the clinic to actually determine complications. There's only so many complications you're going to determine in animal models before you go into the clinic. So we've been able to kind of exclude thrombus, the bubble formations, those sort of things we can exclude. Phrenic nerve injury, esophageal injury, all those we can exclude. But there are other things that we're going to need to get into the clinic. And we're starting to see a little bit of a signal on thromboembolic events in different systems. We need to be aware that this could happen, and this could be a part of the characteristic of our lesions as well. And so we need to keep an open mind as to what that's going to look like. Having an open system has really been helpful in terms of doing that. We are presenting some work at the Heart Rhythm Society meeting, looking at the lesion characteristics, being able to display what we've been learning using these open access system.
Well, I'm very grateful and envious. At the same time, very excited to learn those results. So I wanted to make a couple points, and which to piggyback on what you're saying. One is that PFA's promise is safety. Everything else is secondary. So your point of understanding what is the impact on safety is critical. I think what's also important is what you're doing for all of us, which is lifting the veil and saying, hey, what actually is going on underneath the hood here with PFA? What are we doing? What can we look to change to understand the impact clinically and safety-wise? And I'll also say that I understand that commercial companies took this approach. The regulatory burden is high. The safety requirement is very high. And the investment is huge. So I understand we are where we are. I always advocate for eventually they're going to need to trust us again to impact our lesions in our own scientific way. And so I think this is the first and a very important critical step. I'd like to turn our discussion now to my next question for you. De novo AFib ablation in Australia. What is the energy breakdown that you are finding now?
Yeah, so we've had a rapid transition with the introduction of PFA. That I would say we're close to 100% of de novo cases being done with PFA technologies. There's a number of technologies available, some in the research setting, but we have at least 3 commercial systems now in Australia, and so that pickup rate has increased. So, in Australia, we've had a number of commercial systems that have been available. What has taken a little bit of time to get in is for institutions to be able to get access to these systems. But as access has become not an issue, we've now become almost 100% PFA use for de novo cases. Now, how we manage the redo cases really depends on what we're going to be targeting at the time. And I'd still say we're using about 50% PFA in that group of patients.
I'd like to contrast where we are in the United States at about 60% PFA overall for AFib. Now, Europe has had the longest experience with PFA, but is at roughly around 35%. Now, there are a number of impacts that I've heard from Europeans as far as why they are where they are, one being reimbursement amongst others. Talk to me about how Australia, from a regulatory and overall economic sense, could go to 100% so quickly.
Yeah. So I think there's a couple of issues. So the first is the economic side of things. So depending on where the companies are marketing this in each region and what the region has to pay for it. In Australia, they came in under what was standard cost of an ablation procedure. So cost wasn't an issue for us. The second issue that Europe has is the availability of general anesthesia. So some territories are using deep sedation, which they're allowed to do. We don't have that luxury for the EP to do that in Australia. But we'd already moved to general anesthesia prior to that. And so most AF ablation in Australia was already occurring with general anesthesia. And so that wasn't a breaking point in terms of adoption. So I think they're the two main issues that made it different for us to adapt. The workflow of most of these techniques are actually pretty similar to what we were doing. So it didn't actually impact the lab flow all that much in terms of us taking it on.
I'll ask you to comment. We're here at EHRA, right? One of the most interesting pieces is looking at the single-shot champion trial, which is the randomized trial for about 210 patients where they studied the pentaspline catheter against thermal ablation with the cryoballoon. Very interesting findings for everybody following closely. Your take on that trial?
So look, I was fortunate to be the commentator or the discussant for the trial yesterday. And I think it's an important study. It reproduces the data that we've seen out of Advent, okay, in perhaps a more experienced lab session where they reduced the procedure time and still got a non-inferiority endpoint. The question is whether we have a superiority endpoint here or not. And the p-value for that was 0.046, and it was not a primary endpoint. It was actually a sub-analysis that was undertaken. One of the striking things here is that the cryo results were lower than what we've seen anywhere else. And so we've got to kind of understand why that is, because that's probably driven a bit of this result in terms of superiority. It only takes one person to cross over and it's not a superior result. So at best, we can say this trial was not inferior and they still got the procedure done faster, but it didn't change the outcome. I don't think this is the final nail in the coffin of cryoablation in terms of the results of the study.
Completely agree with you. I think strengths of the study, right? Implantable loop recorders, randomized, but also, questions. How do we interpret the results? What does this mean for the future? I agree. I don't think cryo, this is out and by any means. Takes me to my last couple of questions for you. The first question, if you had to get an AFib ablation, what energy source would you want and why?
Yeah, so I think from a safety perspective, I think the data is for pulse field ablation. And I think the other I would say is I'm starting to gain more confidence that the intra-operator variability is less for PFA than we see for RF for sure, and maybe even cryo. Okay, so I think we're going to need to wait and see that, but PFA would be my choice at this point.
Follow-up question for that. Would you want your operator to do a map for you?
I think mapping is essential. I'm still a mapper. I like to map. I like to know geometry, and I'd like to know the areas that I need to target. So I'd hope that people get to that point of doing that.
As someone who's done a lot of PFA, can you comment on your current thinking around vasospasm with PFA, how you manage it, and how you think about it longitudinally and long term?
Yeah, thank you very much. I think this is a great question, and it's actually really concerning me right now. So I have a lot of thoughts on this. I think we have to first divide it into prevention of coronary spasm and then management of spasm. So those are two different things that we need to anticipate when we do the procedure. And then also there are different types of spasm. There is the acute spasm that we see when we ablate next to, adjacent, in proximity to the coronary artery. And then there's also been reports about generalized spasms. That's one thing. And then we have the acute spasm, but maybe we also have a lesion or injury that we're creating in the coronary. So just to give you a little overview of what's going on in my head right now. Yeah. So starting with the prevention, I think it is important that every time you apply PFA close to a coronary artery, that you think about following along with a nitroglycerin protocol. And they have been investigated mostly by the group around Vivek Reddy, where they have published this bolus protocol where you apply 2 or 3 milligrams of nitroglycerin into the right atrium, for example, or into the vein, and intravenously, just the minute before you start ablating, and then you repeat your boluses every 2 to 3 minutes. That's one of the concepts you can do. The thing is, what if a spasm does occur? And unfortunately, we had the incident that we had a spasm despite prior treatment of nitroglycerin. And it was occurring with a little bit of a delay. So this is something you need to anticipate as well, that the spasm can occur even when you give nitro. And also it can occur a little bit later. So it happened about almost 2 minutes after ablation that we clinically saw the spasm. And depending on which vessel is the one that you targeted, you can have heart block, you can get a ventricular arrhythmia. So you really need to be sure about your next steps. So how you're going to treat this patient. Do you have someone in your clinic who can do a coronary angiogram to maybe apply nitro into the coronary artery? And those are all the kind of things. An easy thing that we have changed in our clinic is to just always use a 12-lead ECG when we perform PFA so that we easily can see the ST elevations if they might occur. But we also have to know that a spasm is very rare, right? Then there are some reports about a generalized spasm, and there is much little evidence towards this, what to do about it, right? It's more about like case reports. There's 2 published case reports about it that we don't really know right now how to treat.
So are you describing these kind of delayed vasospasms?
Yeah.
That could even result in something like sudden death and
Yeah, so there has been a report from the UK, from Reichlin, just published last week actually in Heart Rhythm, where they had a patient in the awakening room with a really immense coronary artery spasm. So that was diffuse from what they were telling us and from the report. So it's just something we need to think about, also about post-procedural monitoring. Obviously, those are only single reports. It's very, very rare that such things occur. But as you said, it's a trade-off and the things we need to feel of, maybe there's rare new complications that we need to know about, right? So that's a really interesting topic right now for me personally to talk about.
No, absolutely. And I guess I want to push you a little bit on this delayed vasospasm issue. Now, is regardless of proximity to coronaries and initial?
Yeah. So the spasm that we found in our center was with a little delay, and that was in close proximity. The other one that was published in Heart Rhythm was, I think, don't quote me on this, but it was about 45 minutes to an hour after the procedure that the patient started having symptoms in the awakening room. So the mechanism,
PFA applied to the CTI or the mitral isthmus, or just
in this
PVI?
patient, no. Yeah.
Just PVI. Interesting. And I think there's a lot we have to learn about PFA. I think it gives us a lot of reassurances and also a lot of questions. As somebody who got in with PFA early, tell me about what do you want most to see from the PFA technology of the future?
So I think, to be honest, we still need to work a little bit on understanding true lesion depth with the devices, because we do see that sometimes PFA doesn't go as deep with the bipolar systems that we are having. I know the industry is working on this, so we can, create more depth for certain areas. This is definitely something that is interesting. I think titration of energy is just something that should be given in our hands. Are we not because we don't really understand the waveform and everything, but I think this is kind of crucial. I like the way how everything is going into the kind of sustainability, area of the field, like having one mapping and ablation catheter. It's good for the patient. You have less access to the LA. It is also good for the environment, I think. So those are things and concepts I think are really, really interesting. I do also like simple technologies, though. We now got so spoiled by some of the systems being so efficient, fast, reproducible. I think it is important to not overcomplicate things if you're just going for sole PVI. So it's going to be hard to make this even more streamlined and efficient. But yeah, those are the things.
Okay, and then the question I've asked everybody, if you had to get an AFib ablation, what kind of energy would you want?
Yeah, I must say I would want PFA because I think there's a eradication of certain complications, right? There's no PV stenosis, there's no phrenic nerve harm, and there's no atrioesophageal fistula. And hopefully, because I'm still young, I would only have paroxysmal AF and I would only get the veins done, right? Yeah. So that's my answer.
So first question for you, and I appreciate all the work you've done in the PFA space, but talk to me about our current thinking for lesion durability in PFA. What are the parameters that ensure a durable lesion, and what's the current thinking in this space, and what's kind of the projections forward?
Yeah, so I think the first thing to say is that the current generation of systems are not getting tissue depths that are any greater than RF or cryo. So that's why we've seen so many trials, including at this EHRA conference, saying that thermal and PFA are basically the same when it comes to efficacy. We're getting about 3.5 to 4.5 millimeters of depth. Furthermore, people have to get used to the form factors of these new catheters. And so although some of the early results suggested we had 95% pulmonary vein durability, we know that manifest redo showed that there were a lot of reconnections. So what I'm looking forward to in the future is having PFA systems that are going to be getting us more like 5, 6, 7 millimeters in depth. I think that way we're going to get more durable lesions. And I think the other thing we need to do is to have some sort of signal analysis, whether it be optics or unipolar signals, that tell us, do we have a transmural lesion or not?
Well, thank you. So I'm gonna put a question to you. It's like a multiple choice question.
Okay.
So you're doing a PFA AFib ablation.
Mhm.
Okay. You have multiple parameters, but you can only choose one to ensure your lesion will be durable. Okay. One is an assessment of contact. Maybe it's an impedance-based assessment.
Okay.
The other is a contact force assessment.
Okay.
And the third is intracardiac echo looking at electrode contact. Which one of those do you want right now?
I'll tell you what I don't want. I don't think contact force is useful for PFA. I think once you're beyond 10 grams, it doesn't matter. Contact is very, very important. And for me, because I have the chance to be able to use intracardiac echo in my geography, I find it incredibly useful. Very, very useful. I mean, you can see what the catheter is doing. If the catheter is not in good contact, you can see the consequences like bubbles. But I know that that isn't available in every geography, but for me, it's a big one.
Music to my ears, Atul. I'll tell you my conversations here in Europe. I think it's very aspirational here, but I think the economics on many levels have made it very challenging. And again, I'm with them on that, but I think what you're saying as far as the unrealized potential of not using intracardiac echo is significant. So I want to take our conversations in another direction. Talk to me about dual energy. I think there's always questions about the class effect on coronaries with PFA, amongst other things. So where do you see the role of dual energy in the era of PFA moving forward?
I think it's an important concept because as you pointed out, in the CTI, mitral annulus, we get coronary spasm. And other than giving very, very high doses of nitro, which I personally don't want to do, there's no way we can avoid coronary spasm. There's no magic PFA sauce that's going to avoid that problem. So my suggestion is just use RF in those places. Don't even, fiddle around with PFA in those areas. It'll be safe. And if you can all do it with one catheter, then economically it makes a lot of sense too.
I'm with you on that. I mean, I think back to our ICE conversation, my current approach is putting the ICE catheter across those regions, really visualizing. In a percentage of patients, really the coronary will not be visible, but in many it will be, and then I'll switch energy.
Yeah.
So, VT ablation. We just came out of Castle VT as far as their projections, but I think I want to change gears and talk about PFA for VT.
Yeah.
We talk about deeper lesions, newer offerings, but kind of what are the exciting spaces for VT with regards to PFA?
Well, we're seeing PFA now make its transition to the V. It's gone from being an A-only technology to a V technology. Obviously, we have some technologies like the Sphere, which are doing early feasibilities, again, combining RF and PF and a mixture of both. We have some newer catheters that are saying PF alone can get up to 10, 11, 12 millimeters in depth. But I think we have to await and see the safety profile of those kinds of things. And then, of course, being able to stack different sorts of energies on top of one another. So we did some work showing that if you were to do a little bit of RF and stack PF on it, the lesion depth would be more than you could get from either energy source alone.
Yeah, that's actually a really important point. I've read some of those papers. Combining thermal ablation and PF is resulting in a deeper lesion, and it does not necessarily matter the order of delivery.
That's right. You got that right.
Yeah.
And that was surprising to me when
Very.
we found that. You know, I thought that for sure we would see a difference depending on the order. The lesion looks exactly the same, you know, really surprising.
Mechanistically, why do you think that is?
Well, I think whether you deliver RF first or PF first, you have fundamentally changed the tissue characteristics. You've lowered the impedance, you've caused some edema, even PF causes edema, and that makes for a more conductive material. And remember, radio frequency is just a type of electrical current that happens to create a lot of heat. So you're making the tissue more conductive for electrical currents.
Very well said, very well said. So final questions I've asked everybody. If you're going to get an AFib ablation, what energy source would you want and why?
PFA, PFA, and PFA. It's safe. You know, I don't want to be thinking about my own esophagus. I don't want to be thinking about my own phrenic nerve. I don't want to be thinking about pulmonary vein stenosis. So PFA.
And would you want a map for your procedure?
You know what? Let me put it this way. Yes, I would, but I would want it with someone who has already integrated mapping into their workflow. So I wouldn't want someone who never uses mapping to say, all right, for you, I'll use a map, because then they're doing something that just doesn't feel right to them. But I do believe in the role of mapping in PFA.
I agree with you. So trust the operator, but probably you want your operator to have integrated mapping.
Yes, exactly.
All right. Well, thank you, Atul.
Daniel, it's always a pleasure.
Always a pleasure.
All right.
And thank you all for tuning in to Heart Rhythm TV.